Hi everyone and welcome back to my channel. Today's video provides a detailed explanation of direct and indirect pulp capping. We'll cover indications, materials, procedures, success rates, and most importantly, how to choose the correct technique clinically. Let's start with direct pulp capping. By definition, it is an application of a protective dressing directly over an exposed pulp due to mechanical trauma or caries removal, to maintain pulp vitality. It stimulates the formation of reparative dentin at the exposure site and preserves the health of the remaining pulp tissue. In direct pulp capping, case selection is very important. We do it when there is a small mechanical trauma or injury resulting in pulp exposure in a tooth showing a vital pulp with no signs of periapical pathology, irreversible pulpitis, and in young patients with open apices. But caries-induced pulp exposures have a lower success rate. Contraindications include the tooth showing signs of irreversible pulpitis, such as spontaneous and lingering pain, and radiographic evidence of apical pathology. Non-vital and necrotic pulp and uncontrolled hemorrhage at the exposure site. If the tooth is showing these signs, endodontic intervention is the right treatment of choice. How to do it? First, isolate the tooth with a rubber dam. Control hemorrhage by applying cotton rolls dipped in saline or sodium hypochlorite. After achieving hemostasis, apply calcium hydroxide or MTA directly on pulp exposure. Place GIC as a base material and place a permanent restoration in the same visit. The pulp will form a dentin bridge beneath the capping material. However, the quality of the seal matters more than the material itself. The success rates are 60 to 80% and are higher in young patients, mechanical exposures, as compared to caries exposure, and when MTA-based materials are used. Moving towards indirect pulp capping. By definition, it is the placement of a biocompatible material over a thin layer of remaining affected dentin near the pulp to avoid pulp exposure while arresting the caries. It promotes remineralization, healing, and continued pulp vitality by avoiding pulp exposure. We do indirect pulp capping when there is a deep carious lesion but no exposure of pulp, no spontaneous pain, a positive response to pulp test, and if it is showing symptoms, it must be of reversible pulpitis. Contraindications are the same as those of direct pulp capping, which is a tooth showing symptoms of irreversible pulpitis, necrotic or non-vital pulp, and visible radiographic pathology. How to do it? First, isolate the tooth with a rubber dam. Remove the infected dentin by leaving a thin layer of affected dentin. Infected dentin is the soft, outer layer of decay, teeming with bacteria, easily removed, and needing complete excavation. And affected dentin is the firmer, inner layer, demineralized but less bacterial, often left behind because its intact collagen can remineralize, requiring removal only until it feels firm and leathery, not soft and mushy. Then place calcium hydroxide, MTA, or bioactive dentin substitute. Seal with a GIC base and temporary restoration. By sealing the tooth, the bacterial nutrients are cut off, and the remaining bacteria become inactive. The pulp responds by laying down tertiary dentin. This makes indirect pulp capping highly successful, especially in young patients. Re-evaluate in 6 to 8 weeks. If symptoms resolve and there's no pathology, restore permanently. The success rate is over 90%, mainly because pulp is never exposed. The materials used are calcium hydroxide, which is an antibacterial, and stimulates the dentinal bridge. The next is MTA, which is biocompatible, seals well, and gives good outcomes. The last is Biodentine, which is a bioactive material and has high compressive strength. A 3 to 6 month follow-up is necessary. A successful pulp capping should show no symptoms, give a normal response to pulp tests, and there should be radiographic evidence of a dentin bridge or no periapical pathology. Vital pulp therapy is a conservative option to maintain tooth vitality. Direct pulp capping should only be attempted in carefully selected cases. The quality of the coronal seal and aseptic technique are critical for success. Use of bioactive materials is preferred for superior outcomes. That's it for today. Thank you for watching. If this video helped you finally understand when to choose direct versus indirect pulp capping, like and subscribe for more Endodontics Simplified.